Uh, this woman is a 23-year-old Dominican woman with sickle cell. We believe SS. We got very little information initially. Living in Chicago, who is visiting family in Dominican Republic. And she became quite ill there and tried to fly back to Chicago, but changed over in Miami. She was taken off the plane, taken to an outside hospital that was not really capable of taking care of her. But they saw her for a sickle cell patient with acute weakness. They suspected a new CVA. She was tested positive for COVID and had respiratory failure, not intubated, but severe respiratory problems. And then she also had a very swollen left knee and E. coli emphysematous cystitis. These are all diagnosed at the other hospital, but she was transferred within a couple of days to us. From her past history, there's very little history. Her mother was with her, but her mother was not a very good historian, and we couldn't find the doctor in Chicago that sees her initially. So she appeared to have a prior history of CVA, had been transfused temporarily, but also got very alloimmunized, which made it very difficult to get transfusions. We didn't know this at the time, and when she reported to the other hospital, she was found this acute CVA symptoms, and they gave her several units of blood. It looks like 5 or 6 units of blood that were not fully cross-matched. Initially, she bumped her hemoglobin up to about from like 5.5 to 7.5. They did a CT of the brain, which was read as no acute changes. But because she was very ill and they couldn't transfuse her, they actually transfused her to us for a red cell exchange, which seemed reasonable, except we couldn't find blood for her. When she arrived here, she had a brain MRI that showed an area of hypodensity on the right MCA, PCA watershed area that didn't appear acute. There was no moya, but that was the reading that neurology. In fact, neurology didn't agree to transfer her initially from the outside hospital. We had to do it through the ICU. She had an echo done that showed a globally decreased cardiac function, and the description of a cardiac MRI was diffuse patchy areas consistent with a COVID cardiomyopathy. She also had high fevers. She was altered. She could not give a lot of information, and her mother was not a very good historian, and that was her traveling partner. At the time, she also grew Salmonella enterica in her blood, and it was sensitive to only ceftazidime and meropenem, and intermediately sensitive to levofloxacin. That ultimately became resistant to levofloxacin and Bactrim became resistant to Bactrim. She also had E. coli in her blood and urine. This was due to this emphysematous cystitis. I hadn't dealt with that before, but that had her also very ill. About a week after transfer, and about 7 or 8 days after she got transfused, she dropped her hemoglobin rapidly from 8.7 to 4.1. The blood bank testing showed she was O positive, but she had many different alloantibodies. I have the highlighted nonspecific warm antibody, but that actually wasn't picked up until, I hate to say it, about 2.5 months into her hospital stay. She had many different antibodies, though. It became very difficult to find blood for her. We sort of scoured the state of Florida, ultimately getting frozen units, et cetera, but we tried to just limit how much we could do. We had a phenotypic match, but we had very little blood that we could find for her. No, she's Hispanic, fairly fair-skinned, and I'll say in my experience, a lot of the people from the Caribbean, mixed race, they often have develop antibodies are kind of difficult to type if they've been over-transfused. So she had a very long hospital stay, but there were 2 major problems during the stay. One was this recurrent salmonella joint and bone infections. The first infection was in her left knee. That was drained and partially debrided, but it was open, drained, and closed. And she did well for a while. She got about 6 weeks of antibiotics, but about 4 or 5 weeks into that, she started developing much worse pain in her right hip. And CT showed, well, imaging showed some destruction of the right femoral head. They took her for a debriding. They did a joint replacement. I'll show you that picture. And they used a marrow vanco cement along with the the joint replacement. And that was about 6 weeks into the hospital stay. She was doing well for a while, but then about 4 weeks afterwards, she was even gone to rehab. She'd gone to rehab, and then she started spiking high fevers again. I think she is still on meropenem. Maybe she just finished it, but quickly relapsed with pain in her left hip. And she underwent a total left hip replacement with the same type of therapy. She had moderate hematomas in the pelvis. These were more serious because she was very, very anemic, and we couldn't find blood for her, and she was not making much blood. So her anemia went down to about 1.5 hemoglobin. Luckily, she's a young person, was tolerating these levels fairly well. But when she did get very anemic, her neurologic status would show probably from these watershed ischemic areas. And when she get very anemic, it would look like she was having new strokes. And then at times the family would panic. And at one point, they actually made her a DNR and wanted to withdraw care on a Saturday night when she came in with a very low hemoglobin to the ICU. So our goal during this hospital stay was to find blood wherever we could find it, and then get frozen units to have available. But we try to keep a level more just above 3 was our target. We thought that was about as safe as we could do, since we were really finding a hard time finding a blood for. So this is the December picture of her hip. And this is after she had a hip replacement. You see all the antibiotic beads she has here. And then this is a cement. They have nice description, surgical description of how they made this cement mixture for the acetabulum, and then the body, and then down into the shaft, which you can see here, though. And this is approximately, a month before she had to get the left hip done. Her left hip is already getting very degenerated with a lot of hypodense areas, and soon that had to be replaced also. So that was that aspect. We had to treat her and keep her on antibiotics for a long period of time. And all the while, we had to deal with her severe anemia. She was very alloimmunized, as I showed you before. She had a hypoproliferative anemia, probably because of severe infection. Her creatinine never went above 1, but she did have very, very low retics throughout this. Parvo was negative, but she was not making cells, often like 20 to 40,000 at most. And so we are trying. Then we started on erythropoietin. The EPO level I wanted to draw beforehand didn't get drawn, but she did get started on this, and it seemed to stabilize her counts a little bit, although she still continued to drop some. CRPs were in the 40s. But the thing that became very obvious is she was so sick she couldn't eat. She was strong enough to refuse an NG tube and a peg. So as much as I wanted her to get that kind of feeding, she ultimately refused, and she was very malnutritioned. So the malnutrition was an additional aspect of her multifactorial anemia. The hemolysis she had was both from her sickle cell to some extent. The transfusions she got we knew they were short-term solutions while we tried to fix the problem and avoid any bleeding problems. And then ultimately, as I mentioned, she developed this autoimmune hemolytic anemia, or warm antibodies that were on the smear. You could seem like she was having some microspherocytes as well, but there's a lot of red cell abnormalities. But at that time, it became a consideration that we would start to use steroids, despite the fact that we're still kind of fighting off this metastatic infection she had. The EPO dose was 20,000 3 times a day. You could argue we could have gone higher, but anyway, we didn't go higher at this point. The danazol is something I tried just to see some kind of marrow stimulant, but I was trying to avoid immune suppression. But ultimately, with the antibodies, we started on prednisone. And I think the prednisone had 2 different benefits. One was that it probably slowed down the autoimmune hemolysis. It also stimulated her appetite. And I noticed that very soon after she started, she began eating much more, and really it was kind of a dramatic change in her day-to-day appearance when she was on the prednisone. I went to 40 a day, and then someone may put her up to 50, but she's not a very big person, and 40 a day is what I ordered. And but there were some benefits, and she had some stability, and I'll show you her labs. Things changed a bit. I think it's cut off at the top here, but this is her pre-albumin on the upper right, and you see it's very low. It was down about 10, And it may have been much lower before we started testing this. But once you start eating and started getting better nutrition, and it went up to, lower 20s. This is just over the last month. This is not the whole hospital course, which started in late October. But this was, you see her hemoglobin actually start to rise. And the last time she got a transfusion was here, the 13th. So 13, maybe this was when she got blood, and that was maybe the result of the blood, but that was the last time she got transfused. So the last couple of weeks, she's had no transfusions and has raised her hemoglobin nicely. She has not had fever. She has not had other problems. And even her reticulocyte count has, bumped. Well, this is the wrong scale, unfortunately, but the far right end is where her reticulocyte count went up significantly. So we did finally get control of her infection, got the autoimmune component probably, and then just stopped feeding her antigens. She was getting a lot of red cells, which sort of drove more and more problems for her. And then finally, just want to talk a little bit about this infection she had. The Salmonella enterica is, she started off and got 6 weeks of meropenem, but she had multiple surgeries, multiple washout procedures, ultimately developed Bactrim resistance. She wasn't getting Bactrim, but she acquired a Bactrim resistance during this hospital stay. And then we have to start figuring what we're going to do next for assuming that these chronic relapsing salmonella infections are not just going to go away without some kind of ongoing management. But that's actually a discussion with ID right now. We're not clear what we're going to do next. And there's a big problem with just the doctor she sees in Chicago is not one of the doctors we would send someone to Chicago. He works at Lutheran Hospital. He doesn't seem that knowledgeable about sickle cell, but he's a nice man. But that's who they want to see. So maybe get her into one of the bigger programs, but they are adamant they don't want to go somewhere else. So that is basically her story. And if there's any questions about this, I guess I went faster than I expected. So I ran through that 4-month period pretty fast. But basically, there were periods where she looked like she was, going to die. We couldn't get red cell production, couldn't get red cells for her. She was febrile, she was altered, looked like she was having new strokes, but she really recovered fully once she got more stable hemoglobin, more stable oxygen. So she had a very rocky course, but now I debated whether to put a picture in now because she now looks like she's going to Mardi Gras. She's very animated and lively, and I feel she's well on her way, but it was quite a rocky few months here with her.
That certainly sounds that way. That's really quite an interesting case. You mentioned a drug, Danzol, and I was curious to know how you used it. It's not something I'm familiar with doing.
Well, Danzol you may be familiar with what otherwise used for, is an attenuated androgen. It was developed for women who had, I'm blanking on endometriosis. So
right,
it was used
that's
to
all I knew of it
decrease
for.
endometriosis. And but it has some immune modulating effects, and being an androgen, it also has at least some potential marrow stimulating effects. And there's data on using it in a number of different things, including autoimmune hemolytic anemia and ITP. It's certainly not a top drug used now, but back when we had very limited options with steroids and maybe IVIG, it did have at least a potential role. It was somewhat of a Hail Mary to try to get that on board, and her liver enzymes have been fine, which is what we follow for that, and I'll try to get her down off that. I may have cut it in half already and may stop it altogether, but she's in a holding pattern, so I don't know what danazol actually did, but she started to do a little bit better. Maybe it helped her appetite some, but whatever it is, it's not something we would generally use. It was more of when you have very few options in a case like this, it was an attempt to try to stimulate her marrow with this very low production, and also see if it could improve some of the autoimmune hemolysis. I used that first before I started the steroids because she still had fevers and concerns about sepsis, but that was why that was brought in.
Did you ever give IVIG, given all the alloimmunization and concern?
No, I never did. I mean, initially, it's possible, I tried to go with this very, very long chart. It's possible she may have gotten a dose of IVIG as a replacement dose as opposed to an ITP dose because she didn't have signs of autoimmune hemolysis. It was basically, sepsis and marrow failure and different things like that. She didn't have a bone marrow done, although they did report a little bit about the activity of the marrow in her hips when they submitted it, but I didn't know what to make of that, so I didn't try to read too much into that. But we didn't give her any IVIG at the time of the autoimmune hemolysis that I can think of. I should check that. That's a good question.
Dr. El Rossi?
Yeah. Hey, Tom, this is Fuad from Emory. I think just a quick question. We've had similar tough situations, not overtly septic, though, that we've utilized eculizumab to help if we had to transfuse least incompatible blood available to just reduce the chance of hemolysis. I think in your situation it may have been difficult with the overwhelming sepsis there, but that's something we've employed, especially when we thought, we didn't have a fully matched, phenotypically matched red blood cells. It's helped. I used to historically use a lot of IVIG and steroids, and lately I've been using more of eculizumab. We are able to get it readily at Grady, which is surprising, but we do. But I'm just wondering if potentially in this scenario, but the infection is probably terrible here.
Yeah, since sepsis and infection were the overriding presentation, honestly, it didn't occur to me. I have used eculizumab in patients who have like a severe autoimmune hemolysis, even a recent patient from the Bahamas who had autoimmune hemolysis and pancytopenia ultimately. I would say that made the difference. It's kind of hard to say because he kind of waxed and waned, went up and down, but we did use that, but we don't have access to that. That was an act of Congress to get the drug at Jackson. The county hospital is very strict on what they keep in formulary, and I had to go through the head of the hospital to get that dose. But he actually started to improve with some other cases. I'm sure across the street, University of Miami Hospital is across the street, and I'm sure they would use it more often than we do.
Yeah, the other thought I had was just that she's somebody that I would have put on 40,000 units of Procrit, that I've even done every day in certain circumstances. And I've also given IV iron at times to help stimulate production. And that the 40,000 every other day with IV iron has definitely helped in a pinch for sure.
Yeah, the 20,000 was, I don't think that was the only time. She might have had different doses. Again, there was a lot of different times when she was on different meds. The MAR on her, if you go back to admission, is about 100 drugs long, but I'll have to see if she may have gotten higher. But at the time, I know she was on 20,000 for most recently as possible. She got a higher dose initially, though.
And is she somebody that that you would consider putting on hydroxyurea plus?
I'm sorry. I forgot to mention that. Yeah, I did not start her on hydroxyurea, but she apparently was taking hydroxyurea at home. I didn't get that for sure. We didn't really have a lot of information. She said she was taking it. The mother said she was taking it ultimately. So I did put her on hydroxyurea. She's been on that for a month or so, and I think that's a factor too. Her MCV is like 150 now, 140 something. So she's responding well. The counts are good. I haven't checked a recent electrophoresis, but now she's off transfusions. We could do that. We'll get one for the road.
It's something I've used in very non-transfusible patients. I've used a combination of hydroxyurea with Procrit, even in acute to keep there. And in her case, given her history of stroke and need for cerebral perfusion.
Yeah, I agree. That was my thinking also. I figured we have to get some kind of stability in her counts. So I did use hydroxyurea and EPO, and maybe certainly could have gone higher. Could have gone 50 3 times a week. But she was, she had that. I guess I didn't increase it because I thought we had other things to correct, but I certainly could have started a higher dose.
Other questions? Feel free to raise your hand. I can mute you.
Can I ask you a question to you guys? Anyone dealt with these multiple recurrent salmonella infections? I know I've had basically have it. Yeah,
it's been a while. The myelitis from salmonella bacteria is really challenging, and The last patient I had was a 15-year-old who had a pet iguana and stayed home after having fevers, and just kept on having these spots come up. And she got chloramphenicol for a bit. That led to, I think, a mitochondrial, like an episode where we thought she might have had mitochondrial dysfunction. But I think that she's probably going to need lifelong suppression with something effective, and it sounds like the options might be pretty limited. It's just really, really hard to clear because you have
exactly.
And
I don't know.
it'll pop up someplace else. So I would ask the question of like, how can you effectively suppress her, and then be really aggressive about surgical intervention if she does have recurrence.
Yeah, that's our situation here. The resistance to Levaquin or the quinolones, resistance to Bactrim, makes it a little less attractive, but I think it may still be worth an option. But the chloramphenicol, I could check and see if they tested for that. But chloramphenicol may be a good choice. Have to worry about the rare marrow failure syndromes, but at this point, she's got to be treated. I actually just yesterday saw another patient who had a salmonella brain abscess without other evidence of disease elsewhere, which is, I hadn't seen salmonella infections in sickle cell patients for years, and I get two, and well,
That's a
I
lot
wouldn't
of
say it's in
salmonella.
short term. Pardon me?
That's a lot of salmonella.
It's a lot of salmonella. The salmonella in a bad place. She looked surprisingly good. I expected when I just hear that she would be just totally out, and she was doing very well. So I guess does chloramphenicol hit the CNS? I don't know, whatever. This is actually more sensitive to other options, oral options, but yeah, she looks surprisingly good. And I don't know if it's isolated salmonella brain abscess. Seems like it'd be pretty rare, but we'll have to keep track of her.
We've had, I have not seen multifocal salmonella osteo, but I've seen a few instances, one that we're dealing with right now, of multifocal osteomyelitis with a different bug. That's just really hard to treat. I found it.
Yeah, it was. I actually,
months.
she actually got control, and seems maybe we have a good option now. But with everything else going on, it was pretty desperate. Even in late January, it's looking bad for her. But she had a good February. So that.
And you said, where is she going back in Chicago? I missed that. She's going back to Chicago, not the DR.
She goes to Lutheran Hospital, and she insists on going there. Her doctor is a very nice guy, although it didn't sound like he was managing or seeing her that often, I should say. In fact, what I learned while she was with us is that we thought she might have Medicaid up at Illinois. She actually had Medicaid in New York. She had nothing in Miami, Medicaid in New York, and she was living in Chicago. So we had a hard time finding anyone to pay for her trip, and ultimately she did get Medicaid in Illinois, and she was there long enough. Hell, she was a resident in Miami long enough to be getting Medicaid. But she had she has Medicaid now in Illinois, and I think that'll at least help her. And hopefully, maybe talk to Victor, find someone up there that I could send her to. But they're adamant they want to go back to this guy. He's Hispanic, and they relate well to him. So I think that's their draw.
Any other questions from anyone? That's a scary case. Well done.
Great case.
All right. Well, that was Dr. Aurora. I feel that you. Oops, I muted myself while talking. Very talented over here. Hopefully Dr. Aurora can follow that up. He is a fourth-year fellow, has done med peds and hematology and hemonc, and is finishing his fourth year of fellowship now at St. Jude's, and with an expertise in sickle cell disease, and is going to discuss multi-organ failure syndrome in sickle cell. And I did just want to apologize. I'll be transitioning to my phone while we talk. I have to pick up a kid. So I just wanted to apologize up front. If you see me disappear and reappear, I'm probably in an elevator.
Great. Thank you for the introduction, Julie. And I'll also start off by apologizing that I'm in the middle of a move, and we're also dog sitting. So now we have 2 dogs instead of the normal one. So it may get a little loud, but we'll power through. So thank you all for being here. And I'm happy to discuss a case that I learned from about 3 years ago now. And I know Yogi's on this call, and Yogi, I did not present the case that I think you thought I was going to, but we'll talk about that case at the end. And so I had a lot of lessons learned about MOGS from sickle cell disease, and I'm hoping to share those with you. So the first thing I'll do is just, I'll show the outline. The first thing I'll do is just review the case presentation of this particular gentleman that ultimately was diagnosed with MODS. And I'll go through that pretty quickly because I really want to spend more time on the epidemiology, pathophysiology, and then the most amount of time on the treatment approaches. So just to give you a background, I'll read through this pretty quickly. This was a gentleman that I saw at the adult hospital. As Julie mentioned, I am doing a dual pediatric and adult fellowship. So this was back at the University of Tennessee almost 3 years ago now. I saw this young man who was 20 years old with a history of hemoglobin S beta null, generally quite a healthy man. Every once in a while came in for pain crisis, 1 or 2 acute chest episodes as a young child, but nothing serious after that. So he presented at 1 or 2 o'clock in the morning during my first month of adult fellowship, as generally happens. So he came into the ED down the street from me here with altered mental status. Mom said that he was otherwise had been healthy up until about 4 hours ago. So this is shortly after dinner time when he began slurring his speech. He started hallucinating, saying he saw his grandma and grandpa and they had died many years ago. So something that's somewhat important was that he was seen 4 days prior at a different hospital in Memphis with a pretty prolonged pain crisis. At that time, it involved his lower back and his bilateral legs. He was given some IV morphine and sent home on some pain medicines. And Mom said he's been adherent to his pain medicines. You know, he has infrequent pain crisis, but she's confident he didn't overdose. She's confident that, you know, his pain isn't much better, but it's not getting worse. But he did complain about the pain that had persisted for the past couple of days. So again, just his brief sickle cell history. He had had a remote history of acute chest, but nothing recently, no intubations, no ICU visits. He had never had a stroke. He was not on chronic transfusion therapy. I lied, I said 2 to 3 times. I guess it was a little bit higher. He would have 4 to 6 pain episodes, but it wasn't every pain episode that led him to the hospital. I think it was very few that did that. Otherwise, from a sickle cell perspective, quite unremarkable, no retinopathy, AVN, splenic sequestration, priapism, DVT, etc. And he was really only prescribed hydroxyurea, vitamin D therapy, as well as some pain medicines as needed, and then Miralax when he was on those pain medicines, which Mom said that he had been taking with really no issues. So I'm just going to jump straight to the labs. I will say on exam, before we go into the labs, on exam, he was like ANO times 1, 1.5. He could tell me his name, but he couldn't really tell me where he was. He didn't know he was in the emergency department. He thought there were like 6 people in the room, and really it was just me and his mother. His vitals were grossly stable except for some tachycardia. And from a neurological exam, he, like I said, ANO times 1-ish. And he couldn't really do the finger to nose exam with me because he just couldn't follow my commands. But he otherwise had normal like strength throughout his body and sensation when he could follow my commands. So his labs are pretty significant here. You'll note in my fishbone diagrams with the leukocytosis to 28, a hemoglobin of 4.6, his baseline was around 8, 8.5. He has mild thrombocytopenia to 115 with his baseline being around 300. And you'll see that he has a little bit of macrocytosis, which tells us he was taking his HU. And then that retic count is not as robust as we would want. From a renal standpoint, he had hyponatremia, hyperkalemia. He had elevated BUN. He had an AKI to 2.87. He had never had a known kidney injury before. And then he had a lactic acidosis to 15. You'll see there. But we move to the bottom left. That's the LFT charts with the top being T-billy. So that's 5.1 with the D-billy written in the bottom right of that diagram at 3.1. Going across there, his AST, ALT are elevated to the 400 and 100, and then his alk phos is 415. And then in that T fish diagram, kind of in the middle bottom there, that's my coags. So PT, PTT, INR elevated slightly, nothing that's super crazy, but definitely elevated. And you'll see a fibrinogen of 4.2, and that's the VBG listed there because he was in the adult ED. Urinalysis was grossly unremarkable except for some blood. And then his urine tots, at least the rapid screen showed that he had been taking opioids, which is what we expected. His CRP was really high, and then his RVP and DAT were negative, and RVP included COVID and everything, because this was in the heyday of one of the many strains of COVID. So the ER went ahead and got a chest X-ray and a CT head, given his altered mental status. He did have some fevers at home, but he was not febrile on presentation. So the chest X-ray on my read, I maybe noticed a little bit something in the right lower lobe. They read it as bilateral infiltrates and were concerned about a pneumonia. And then the CT head, this is just a screenshot of one of the slides, but that was grossly negative. We did ultimately end up getting an MRI, which again was normal as well. So as a first-year fellow, this is what scared me, because in fellowship, we're taught what is going to kill the patient first and treat and triage that. So although I knew this gentleman had a history of hemoglobin S beta null, I do see a few sickle cells here and there. I also noticed a few blister cells. He didn't have a history of G6PD as far as I knew. But what really concerned me was that I saw a small handful, but a convincing handful of red cell fragments. And so I remember calling my attending in the middle of the night. I think at this time, by the time I drove in to see him, I was concerned of TTP. I had not, and I'll admit, this is, again, lessons learned. As a first-year adult fellow, but second-year hematology fellow, I was not very familiar with multi-organ failure syndrome of sickle cell disease. And so that was not at the top of my differential. But what I had in front of me was a gentleman with altered mental status, a reported fever, AKI, mild thrombocytopenia, pretty much the hallmark of the pentad you think of for TTP. And so that was kind of what I tunnel visioned to. So a little bit of his hospital course. He was started on broad spectrum antibiotics by the ED, vancomycin and cefepime. We collected blood cultures from him, which ultimately bore nothing. He was admitted to the ICU. Given his severe anemia and his altered mental status, my attending said, yes, I'll consider your diagnosis of TTP, but I'm more concerned with multi-organ failure syndrome. The treatment that I'm going to go with here that I'm going to recommend is red cell transfusions. And then if that fails, we can consider an alternative therapy. So we administered 2 units of packed red blood cells. He was placed on high flow, although he was only mildly hypoxic to, I think, like low 90s at that time. So a really big concern, again, think about what could kill the patient first. Nephrology was appropriately consulted given his severe AKI, but more importantly, his hyperkalemia at a 6.5. We were very concerned about that. So when we repeated, it was still high at 7.2. And there was definitely an element of hemolysis there, but the concern was high enough that we went ahead and inserted a VAS cath in the ED and immediately started hemodialysis, I think by 4 o'clock in the morning there, which was quite impressive by our nephrologist. They did do a little bit more workup. They did some more urine studies and a real ultrasound, which was grossly unremarkable. As I mentioned, this is a young boy with no known CKD, even though he does have sickle cell anemia. He had no known severe kidney disease as far as we knew. So in terms of kind of his hematological parameters, after the 2 units, we saw a slight bump in the hemoglobin. I think it was up to about 6.5 or so. So he did respond. His platelets only budged up to about 130 or so. His creatinine was improving. Probably more with the hemodialysis than with the actual blood transfusions. And his altered mental status, about maybe 6 to 8 hours into his admission, wasn't really improving after he'd gotten about 2 units. So it must have been 8 to 10 hours after his admission. And so with that, my attending and I had another discussion, and we revisited this idea of giving him another transfusion since he was still a little bit low at 6. And then I had learned about the potential use of plasmapheresis in the setting of multi-organ failure syndrome. So this is kind of what we were laying our head on. When my attending reviewed the smear himself in the morning, he did not agree that there were as many schistocytes as I had been concerned about at 2 o'clock in the morning. And he's been practicing for 25 years. I've been practicing for 2. So I trusted him. And he was more concerned about this multi-organ failure syndrome. Again, something that I wasn't familiar with. He had mentioned that in some cases previously he had used plasmapheresis. And so for what it's worth, we did send an ADAM TS13, but this gentleman's plasmic score was really low. I would think it was 2 or 3, which gave him a 0 to 5% chance of having TTP. And so we ended up giving him the plasmapheresis more for the multi-organ failure as opposed to the TTP, which is what I had initially been concerned about. Needless to say, we saw a remarkable improvement, remarkable. So midway through the next day that I saw him, about noon or 1 p.m. after he had had one session of plasmapheresis and about 3 units of blood, he was alert and oriented times 3. He knew his name, he knew where he was. He wasn't entirely too sure what had happened, but all his lab parameters were significantly improving. And so by 2 sessions later, maybe the next day sometime, by his 3rd or 4th hospital day, we could stop his hemodialysis. And ultimately within 3 or 4 days, after that, he left the hospital with just some PT because he was a little bit deconditioned after a lengthy stay. So this kind of brings me to the definition of multi-organ dysfunction or multi-organ failure syndrome. You may hear as MODS or MOMF of sickle cell disease. So it is what I would consider a poorly or underappreciated diagnosis of sickle cell disease. Many people agree on this definition, that it's a vaso-occlusive crisis complicated by life-threatening organ dysfunction, generally of 2 or more organs. We believe that it is caused by sequestration of sickle cells, which leads to microvascular occlusion and then tissue ischemia of the organ in question. We also know that it may or may not be exacerbated by an infection or sepsis. That's generally the first thing we have to rule out. That is most often the trigger, but that may not be the case in all patients. And the unfortunate truth is that there are very, very few reports and very scant literature out there that define the diagnostic criteria and the overall management. There's definitely agreed upon literature out there, but most of it is just in case reports, case series, at least when I talk about the treatment methodology. And yet definition-wise too, this is some place that's a little bit lacking as compared to things like acute chest syndrome or even ischemic stroke. So the criteria for diagnosis, as far as I can tell, was first made back in 1994 by Dr. Catherine Hassel and her colleagues, Dr. Jim Ekman and Dr. Peter Lane. And this was in combination of folks in Colorado and Atlanta, Georgia. So at this time, these 3 physicians essentially said that this is a recognized complication. We believe it's caused by sequestration of sickle cells. And the 3 organs that are most often involved and that should be included as part of the diagnostic criteria are going to be your lung, liver, and kidney. And specifically, when we think of the lung, we think of an infiltrate and hypoxia. So, acute chest in that sense. And then with the liver, we think of an elevated ALT, bilirubin, direct bili, and PT. So now we're thinking maybe a sickle hepatopathy that's included with that. And then finally an AKI, which they defined here with a creatinine above 2.0. So this slide on the bottom right, you'll note here, I borrowed this from Dr. Cantor and the NASEC folks. So this is a topic that has been discussed as part of the National Alliance. And so these next 2 slides are borrowed from them, but you'll see largely that the definition here agrees with the definition that was previously brought forth back in 1994. So here the group defines MOFS or MODS as a clinical syndrome that involves acute organ injury. So again, when we have somebody with chronic kidney disease or maybe chronic lung disease, we have to think of not just, if the hypoxia is 3 liters, well, what if their baseline is 3 liters? So it has to be an acute injury that is above their baseline, resulting in damage to at least 2 organs instead of vasoocclusion. And the main things that NASEC says that we should do is recognize a syndrome. And I agree, I feel like this is quite under-recognized. Treat the potential cause, which may be sepsis and maybe a prolonged pain crisis, and maybe an acute chest that then flares into severe acute chest and ultimately MOFS. And something to note is that this may require prolonged recovery. The organ systems that this again is borrowed from NASEC, the organ systems that they include, include many of what's discussed by Dr. Hassel, but also besides creatinine, which now is actually defined as an increase in creatinine from baseline as opposed to just a level of 2 or above. They also include acute liver injury, as well as lung injury. However, the 2 that are also included are going to be encephalopathy and then thrombocytopenia or severe hyperhemolysis. And so you'll see in our gentleman, he definitely had encephalopathy. It was lack of orientation for sure. And it was well out of proportion to an opioid-induced sedation. And I trusted his mother when she had said that, she watches him, he takes his medicines as prescribed. She had no doubt in her mind that he had been taking them as he should have and did not think that he had overdosed. And similarly, our gentleman had thrombocytopenia. His baseline was around 250 or 300, I believe, and his platelet count on presentation was 115. So he fit the 5 criteria here of AKI, liver injury, encephalopathy, lung damage or pulmonary damage, as well as hematologic damage. I do want to take us back to the Dr. Hassel paper, because this is one, again, that really defined, as far as I can tell, was one of the first definitions in American literature of MODS. So here, Dr. Hassel and her colleagues, they reviewed 17 episodes of MODS, which were identified across 14 patients. So a few patients actually had multiple episodes of these. By and large, most of these patients had sickle cell anemia with either SS or S beta null, although 4 had a hemoglobin SC. The age range, as you can see here, was very wide, between 6 and 60 years old. We use a diagnostic criteria based on their definition in 94. Interestingly enough, none of the patients here actually presented with sepsis or severe infection, but instead all of them presented with an unusually severe pain, or unusually long severe pain crisis, and that is consistent with my patient. Many of them developed encephalopathy, and then only a few of them had ultimately maybe had fever and then developed a positive blood, urine, or sputum culture. So a small minority of those with an infection as a backdrop. A little bit more from her case series here, just showing that after the treatment with transfusions that they had done, you'll note that hematologically, I'm sorry, I apologize. This graph is at time of diagnosis. So the bullet points on the left of both graph are the baseline for these patients, and then the bullet points on the right or at presentation, which help these physicians make the diagnosis of MODS. And so hematologically, we saw that all 17 episodes across these 14 patients were associated with a drop in hemoglobin and platelet count. That goes along with the sequestration type thing. Reticulocyte count supposedly remained elevated, although in our patient, it was a little bit suppressed. Many of our patients, or many of these episodes, had pulmonary involvement, hepatic involvement, renal involvement. And so this is just the case series that helped this group come up with that diagnostic criteria, I should say. One thing that they did ask, which I will admit I didn't see discussed very much in many papers, but comes up a lot when I've discussed this with other physicians, is there a predisposition? So Dr. Hassel and her group did ask this question. And so the short and long of it, even 30 years later, is that it seems to be quite unclear. So of the 14 patients in the case series, all of them had baseline normal renal hepatic function. So none of them had severe underlying liver disease or severe underlying CKD. A few of them had acute chest, a few of them had CLD, and a few of them had other kind of a smattering of sickle cell complications. But there was nothing that really cinched that, oh, this is what definitely predisposed this patient to an MODS-like picture. However, as I mentioned previously, what was unique about this cohort, which may be different than other cohorts, is that this cohort had all of them had a quote unquote more severe pain crisis, which is interesting. I would say that could that be kind of an alarm that, okay, my normal pain crisis lasts 5 to 8 days, but instead I'm now 10, 14, 16 days. You know, should the physician, to the sickle cell doctor, be a little bit more like on alert that could this patient be tipping into an MODS-like picture? And so I think that's a bit unclear even to this day. Treatment that was described by Dr. Hassel and her colleagues was aggressive red cell transfusion, and this continues to be the mainstay of treatment for MODS. Once you have recognized it, you provide the patient with either a red cell exchange if they are, privy to it, or you treat them with red cell transfusion, because the goal is to treat the underlying vaso-occlusion. For what it's worth, even if these patients are undiagnosed or maybe quote unquote misdiagnosed with severe acute chest syndrome or hepatic sequestration encephalopathy, they are going to get aggressive red cell transfusions. And so even if we don't realize that we are treating MODS, we are, because it is the appropriate treatment, not only for MODS, but for things like hepatic sequestration, acute chest syndrome. And so in this case series, we saw that 8 episodes were treated with simple transfusion, 9 got RHCE, or red cell exchange. And for all of these episodes, they saw clinical improvement within 24 hours. However, one patient died, and their autopsy showed a bilateral fat pulmonary emboli, which is an also known predisposing factor to developing MODS. So not unsurprising, I'll say. And the good news is for most all of these patients, the organ function, the LFTs, the pulmonary, and the creatinine all kind of return back to baseline with some time. And this goes back to what our NASEC folks have mentioned to us, that sometimes these patients will take take a long time, and that's evident in this case here, almost up to 6 months to get back to their baseline. So finally, I'm going to talk about the role of plasmapheresis. I understand there's a few things in the chat, and so I want to get to that, but first, I only have a few minutes, so I'm going to run through this quite quickly. But this is what I learned and I found to be the most interesting. Because this had improved MODS symptoms in our patient, I did want to explore this a little bit further. And so we have to kind of go back to the basics, which we're all familiar with on this call, which is that sickle cell disease is not just a quote unquote simple manifestation of red cell lysing, but it's not just the lysis, but what comes after the lysis. And a lot of that, which has been a main focus of many of our target drugs for the past 10, 15 years, is the inflammation and the free oxidants that are a result of this chronic or even acute sickling and hemolytic process. And so what we have to remember is that there's a heavy burden of vasoactive mediators and inflammatory markers that are a result of the sickling and hemolysis. And so these will go on to then attach or attack our endothelium. And then that leads to even further inflammation, which can then lead to further hemolysis and vaso-occlusion. And so it's just something that we have to keep in mind, because if we can remember this pathophysiology, it may show us why plasmapheresis actually plays a role. And so this is again, you'll forgive me, I'm a fellow, but this is how I kind of broke it down. I said in my body or my patient's plasma, there are these kind of modulators that may lead to inflammation or accumulation of platelets and increased adhesion in the endothelium. And I think with plasmapheresis, what I'm doing is I'm physically removing many of these thrombomodulators or these kind of vasoactive mediators. And so I'm physically just taking a few of them out, leaving my patient with less of them to cause less inflammation. So in theory, this is kind of how I think about what plasmapheresis is doing. But wait, there's more, and I'll get to that. So a few case studies have actually reviewed the role of plasmapheresis, and so we're not the first to describe it, or unless my attending was not the first to use it. Dr. Zaidi and their colleagues reviewed 7 patients that had MODS that was refractory to red cell exchange. And so despite the team trying to keep the hemoglobin S less than 30%, our patients continued to have evidence of organ failure. And so they noted that in all of their patients, at only 1 episode of plasma exchange, they noticed an improvement of their lab parameters and hemolytic parameters. And unfortunately, they had 1 patient out of these 7 that passed away, although it was unclear. So I've highlighted here a few of the patients. So you'll see patient 5, patient 6, patient 7. And just a few of the categories that changed quite drastically was the total bilirubin and the LDH, which speak to the hemolytic parameters. You'll see in patient 5, it dropped from 11 to 6.3. The LDH moved from 900 to 380, and so on and so forth with many of our other patients. And so all of these patients were refractory to red cell exchange. However, they improved significantly with just 1 round of plasmapheresis or plasma exchange. There was a more recent trial that was done. It wasn't a trial, I apologize. A case series that was done. This is by Dr. Webb and their colleagues. This was actually published in June of 2023. So just about 8 months ago or so in the Journal of Transfusion Medicine, I believe. So here they had 11 patients, 12 encounters in Dallas. All were diagnosed with MODS and were in the ICU. Here they compared a red cell exchange group to a group that was not as responsive to red cell exchange, but still got it, and then ultimately ended up getting PLEX. They used what's called the Sequential Organ Failure Assessment Score, which is a SOFA score, and they use it across the hospital admission as well as the ICU, and then post-RBC, post-PLEX, and then at discharge. So the blue bar here are those patients that received both red cell exchange and plasmapheresis, and then the orange bar is those that only had red cell exchange. And so you'll note, if you look at the top right of this chart, that the SOFA score change was significantly higher in those that received the exchange and the plasmapheresis as compared to those who just got the exchange. So you had a larger decrease in your SOFA score. And similarly, the subscores looked at just the hematological parameters as well as organ parameters that are shown here. Again, you'll see that there is a difference in the, I guess this is pre-plex and post-plex for those patients who only receive plex. And by and large, you'll see, except for the renal, that there's a change in those hematological and organ parameters. And then last but not least, again, just a graph kind of highlighting again the role of platelet activation, endothelial activation, and these mediators that kind of just cause a lot of cytokine release in our patients as they undergo a sickle cell crisis. And so you'll see here that we get a lot of free oxidants, we get a lot of free heme. But what I want to point out here are those that are shown in red, these proteins called hemopexin and haptoglobin, which do a great job of actually binding to these free radicals to help try to reduce the amount of inflammation that our patients with sickle cell are experiencing during one of these crises. And so as such, we know that haptoglobin and hemopexin are proteins responsible for binding or free heme. There was a study done in Brazil, and unfortunately, I don't have the exact details. However, what they did was they did knockouts of haptoglobin and hemopexin in mice and put these mice under hemolytic stress, which ultimately resulted in significant renal and tissue damage. And so what they noticed was that those patients with hemoglobin SS had about 8% of haptoglobin and 14% of hemopexin as compared to those with hemoglobin AA. And so actually, I apologize. Those with the knockout haptoglobin hemopexin suffered significant renal damage and tissue damage. The same study told me that when you look at a human population, you'll see that the SS patients have significantly less of these proteins as those with AA, which is not surprising since they're using so many of them up. Now, another lab decided to test this hypothesis and actually administered exogenous haptoglobin and hemopexin, either independently. I'm sure there's a form that you can get of its pure derivative of haptoglobin or hemopexin, but we could also use FFP because there are significant amounts of haptoglobin and hemopexin here. So on this note, there was a study done not too long ago that examined 4 patients with MODS that were refractory again to RCE. Here they got aliquots of FFP because we know that FFP have haptoglobin and hemopexin, and they measured their hemolytic parameters pre and post the FFP. And the long and short of it is that all of the hematological parameters by and large improved. And not only that's shown in the graph on the left, but if you look at the graph of the table on the bottom right, you'll note that are we actually, is it the haptoglobin and hemopexin that's playing a role? And I think you can draw that conclusion because you'll note that the patients pre and post FFP had massive bumps in their haptoglobin and hemopexin. So it's telling us that potentially yes, and I'm not drawing I'm not saying a causation here, but potentially yes, that the haptoglobin and hemopexin are actually what's binding to my free radicals and potentially decreasing the deleterious tissue damage that's going on because of the oxidants and the cytokines that are in the plasma. So in conclusion, MODS is rare, but it is life-threatening. I believe it's quite underdiagnosed. There are, as of yet, no identified predisposing factors, but as shown by Dr. Hassel's study, there may be some patients that present with prolonged pain crisis. The NASAC folks, when I read through their information, had taught me that infection sepsis is also a predisposing factor. We should always consider it, though, regardless of whether there's a predisposing factor, when our patients present with numerous tissue damages. So lung infiltrates, hypoxia, anemia, thrombocytopenia, coagulopathy, transaminitis, encephalopathy are the big ones to consider, and that's represented by the NASAC guidelines. The mainstay of treatment continues to be red cell transfusion and supportive care, potentially even doing a red cell exchange. However, I would argue that there is a role, or some may say there may be a role for plasmapheresis in the process, as studies have shown us that it can decrease inflammation and tissue injury, secondary to ongoing hemolysis, and then bind to those free radicals and free heme that are causing so much damage to our end organs. And so now to make Yogi happy, I did want to put in a plug. This was a really interesting case that we had, not the case that I'm currently presenting. The case that I presented was 3 years ago. However, we had a case just about 6 months ago. This was at the St. Jude side, where we had a young girl who has type 1 diabetes as well as hemoglobin SC. She presented with DKA and sepsis and was found at that time to have MODS. She was unresponsive to red cell exchanges, but through some discussions with the attendings and the UT groups, which I think is the beauty of the camaraderie of academia in not only at UT and St. Jude, but just in general when we talk about sickle cell. One of us proposed doing some plasmapheresis. Unfortunately, she improved significantly, was taken off pressors, was extubated, and has been discharged and is still undergoing PT. And we're very fortunate that this has been accepted to ASFO as a poster. So if you were there, spoiler alert, you know how this ends. It ends well. But Dr. Eric Rydell, who is a MedPeace resident at UT, and did a lot of care for this young girl, will be presenting this case. And so with that, I apologize for rushing through, but I'm happy to take any questions, comments, and I will read through the chat in the meantime. So thank you so much. So I'll oh, I'm sorry. Please, Dr. Harrington, go ahead. Yeah, I was reading your question out loud, but please, you're welcome to ask it now.
Yeah, this Marfan syndrome that we see, it is really critical that people recognize it, and generally they're going to present with the worst pain of their lives beforehand. It's interesting, this kid seemed to present with altered mental status at home. Did he have the excruciating pain prior to that?
So excruciating, it's tough, but based on mom's description, this was a gentleman who did not routinely suffer from prolonged pain crisis, and she said this seemed out of the ordinary for him. That usually within a day or two after the hospital, it would resolve because he was a really active guy, and she said for it to be going on 3 or 4 days was unusual. So, yeah, we could argue that it was more severe for him. Yeah,
I've had two recently like that. One was a woman on vacation who was developed this when she was in Miami Beach and just was altered. They didn't know she had severe pain, and she had all the findings of Marfan embolism, including a very dramatic punctate emboli throughout her brain. Hundreds of little black dots. It was quite impressive. And another one who didn't come in with very severe pain, who quickly developed the same picture. And he's someone who's had a lot of problems. And in fact, he was on chronic exchanges at the time of this happened. And both of them did very well with plasma exchange, which is now our standard approach also.
So this is Julie. I am going to just put a plug in that two things. One, we are going to be publishing these recommendations when we get all our other recommendations published from the NASAC side. So many of you will be voting on final recommendations. And two, we may consider an investigator-initiated or NASAC trial that looks at this in some way. And I saw Dr. Lima's question, who works over at UAB, and I don't know what you all do. What we have done in terms of Plex, as I've plexed until I see either their LDH reducing significantly and consistently, or other signs of organ recovery. So I wanted to put that out there as a question.
Julie, we don't plex here at Grady. We like, and this is just for the sake of the argument about the use of plex here. And we definitely continue, proceed with the red cell exchange and see what happens. And we have a monthly, at least 1 or 2 cases of multi-organ failure. I mean, Tarun, if you want to do a better report on this, let me know. But
we do too. We see it a lot.
Yeah, we see it a lot, but we don't plex. And yeah, I mean, just for the sake of the debate, I put that in there because only if you see persistence potentially of hemolysis parameters and you've achieved an S percentage less than 30%, maybe you should consider the plex then. But
that's actually, that's exactly what we do, what you just said.
Yeah. But in our experience, I mean, the amount of plexes we've done are minimal. That's what I can say.
So we've done it in unrecovered instances or instances of.
Exactly. That makes sense.
And Margot, do you want to say your comments out loud?
Am I oh yes, I am unmuted. No, I was just going to say, at the Children's Hospital here in Atlanta, we actually do plex for multi-organ dysfunction outside of sickle cell patients, and we do it quite frequently. And so the course is usually at least a 5-day interval. So we do it daily for 5 days. So it's interesting that you just did it for 1 day. But I guess if you do the red cell exchange on top of the plasma exchange, the patient has essentially gotten a full whole blood exchange, so they should be much better. But I did have a question. Let me scroll up because there was a question about the patient that you had with diabetes. I was just wondering if she, I think my question was, did she have hyperhemolysis prior to her red cell exchange? Because it sounds like you did red cell exchange ×2.
We did.
And I didn't know if you had hyperhemolysis that presented with her multi-organ dysfunction as well.
That is a great question. And I unfortunately was not involved at the beginning of her case. And I saw that Yogi has signed off. So unfortunately, I do not.
No, I'm still here.
Oh, I'm sorry. There you are. Yeah, Yogi, did you answer that?
So it was hard to tell if she actually had hyperhemolysis. When we looked at her LDH, it was, I think, over 1,000, but her LFTs were pretty severely abnormal as well. Platelets were normal, and her smear was actually no. I didn't really see that much schistocytes. We did give her, so when she came into the ER with her DKA, she was pretty severe and hypotensive. The ICU ended up giving her a unit to 10, and she held on to that unit. The reason that unfortunately hematology got involved later than we expected was initially they thought her altered mental status was because of the DKA, but once the DKA resolved, her altered mental status continued. So then they were like, oh, let's consult hematology. And then when we looked at her labs, we saw elevated LDH, her initial anemia, we saw the DKA, sorry, not the DKA, the AKI and the abnormal LFTs. And we decided to do the red cell exchange. Her S was down to like less than 30%. I think it came down to like almost single digits. And then after the red cell exchange, we decided to do the plasmapheresis because her LFTs kept rising and her AKI kept getting worse. Interestingly enough, it was Tarun who actually brought his previous case to our attention, and we went to the plasmapheresis. But we wanted to eculizumab because some of the intensivists had experiences with eculizumab prior to this case. So, but we decided let's try the plasmapheresis since we've already done the red cell exchange. If that fails, then we will do eculizumab, and in the meantime, give us some chance for the terminal complements to come back, which I think those ended up being normal.
Excellent. Well, thank you all. This was a great session and really appreciate everyone's attendance. And I hope you all have a fantastic rest of your day, and we'll see you in a couple weeks.